Good day, everyone. Thank you so much for this invitation to give an update on preeclampsia screening and prevention. Here are my disclosures. So let me start with first trimester screening for preeclampsia. Here are two professional recommendations that utilize a risk scoring approach. The first is the NICE guidelines from the United Kingdom, and the second is the ACOG guidelines from the United States. They're rather similar, as you can see. If a woman has one high risk factor or two or more moderate risk factors, then she is considered high risk and is advised to take 75 milligrams or 81 milligrams of aspirin from 12 weeks till the birth of the baby. This approach is simple, but its predictive value is limited, achieving only 30% and 39% detection rates for term and preterm preeclampsia respectively. Another issue is that such an approach to screening has led to a rather poor uptake for aspirin prophylaxis, as shown in one of our studies that only 23% of high-risk women determined by the NICE approach had aspirin prophylaxis. It is clear that we need to improve the method of screening for preeclampsia. After years of research, we now advocate for the use of the competing risk approach, which has the advantage of allowing assessment of individual patient-specific risks of preeclampsia that requires delivery before a specified gestation. In addition, the use of Bayes' theorem to combine maternal factors and a series of biomarkers provides a natural framework for dynamic prediction in which risk assessment is updated as new information becomes available during pregnancy. Incorporation of biomarker information using likelihoods means that new markers can be added by extending an existing model rather than developing a completely new model. This approach also takes into account the increasing effect of biomarkers with the severity of preeclampsia. The first trimester combined test of maternal factors, mean arterial pressure, uterine artery Doppler, and serum placental growth factor achieves excellent prediction for early onset preeclampsia with a detection rate of 90% at a false positive rate of 10%. The detection rates for preterm and term preeclampsia are 80% and 45% respectively. Although the model achieves a lower detection rate for preterm preeclampsia as compared to early onset preeclampsia, it already provides sufficient prediction for us to prevent the disorder effectively with the use of aspirin prophylaxis. As shown in this UK NIHR-funded SPREE study, the first trimester combined test doubles the performance of screening for early and preterm preeclampsia and even term preeclampsia as shown by the blue bars in comparison to the pink bars of the traditional method endorsed by NICE. As part of this combined test, it is important to ensure that these biomarkers are measured according to standardized protocol. And here, I share with you the protocol for the measurement of mean arterial pressure. Our tip is that for the measurement of blood pressure, it is best to measure in both arms simultaneously so it is not time-consuming, but you must ensure correct posture of the woman. We also recommend that you use validated automated and semi-automated devices, and the women must be well rested before the blood pressure measurement. Then arms should be supported at the level of the heart. With the use of correct size cuffs, then you should take 2 measurements in each arm simultaneously, and altogether you take an average of all 4 measurements for risk calculation. You can scan the QR code here for a more detailed description. And here is the protocol for the measurement of uterine artery pulsatility index. In the first trimester, we recommend that we measure the uterine artery PI via transabdominal ultrasound. The way to identify the uterine arteries is to firstly apply the transducer longitudinally over the suprapubic area to obtain a sagittal section of the cervix, and then use color Doppler. Gently tilt the transducer to the side of the uterus to identify the uterine arteries at the level of the internal os, as you can see in the top picture on the right. Using a sampling gate of 2 mm to cover the whole vessel and ensuring the angle of inclination of less than 30 degrees, you obtain the waveforms as seen in the bottom picture. It is important to check that you have indeed sampled the uterine arteries. So to check, you need to make sure the peak systolic velocity is more than 60 centimeters per second, and then you measure both left and right uterine arteries and take an average of the two for the risk calculation. The key to easy measurement is to know the anatomy, and fixing the transducer in the midline and then tilting the transducer to the side of the uterus slowly would allow you to see the uterine artery at the level of the internal os easily. The Doppler settings are as follows. The pulse repetition frequency, PRF, of color Doppler is maintained between 3 to 4 kHz. The scanning speed should be adjusted so that there are 4 to 10 waveforms on the screen. The PRF is adjusted so that the size of the waveform occupies 50 to 75% of the scale and a low-pass filter is used. You can scan the QR code here for more detailed description. The third bar marker is placental growth factor, and here I want to share with you some technical considerations. When you take blood, make sure that the bevel of the needle faces up when you insert the needle. And after collecting enough blood into the blood tube, then you need to invert the blood tube 5 times gently in order to allow thorough mixing of the blood with the medium. Afterwards, the blood tube needs to rest for 30 minutes to allow the blood to clot, and then you insert the blood tube into the centrifuge for spinning. Following this process, you need to check the quality of the serum against a standardized chart as shown in this picture. And here I want to share with you our experience in a clinical setting, and this report belongs to a test case. We adjust the placental growth factor according to certain maternal characteristics and gestational age in order to generate the MUM value, the multiple of median value. And then this is the part in relation to the reporting of placental growth factor. This value is the raw value, and the value in the parenthesis is the MUM value. And so this value is close to 1, suggesting that the MUM value of placental growth factor in this case is relatively normal. So moving on, a gentle reminder that in 2019, we collaborated with Fetal to issue these best practice recommendations. Here we recommend that published algorithms should be used for converting the measured values of mean arterial pressure, placental growth factor, uterine artery pulsatility index, plus or minus PAPA into MUMs. Patient-specific risk for preterm preeclampsia is calculated using the base-based method, as I was explaining to you about the approach that the competing risk approach, using the base-based method as presented earlier. A woman is considered high risk when the risk is at or above 1 in 100 based on the first trimester combined test. We recognize that the combined test is most predictive of preterm preeclampsia, but not term preeclampsia, and that the best model is the one that combines maternal factors with mean arterial pressure, placental growth factor, and uterine artery pulsatility index. And this QR code will take you directly to our risk calculator online, which is free of charge. In clinical medicine, number needed to treat is a tool for measuring screening benefit. According to the ASPRE data, the number needed to screen to prevent 1 case of all, preterm and early preeclampsia, 143, 250, and 400 respectively. The number needed to screen for preventing 1 case of preterm preeclampsia is equivalent to the number needed to screen for the prevention of 1 case of early infection due to GBS through universal screening at 35 to 37 weeks of gestation. Compared to screening tools in clinical oncology, this number is lower than the number needed to screen for the prevention of any cancer listed on the left. So now let's move on to first trimester prevention of preeclampsia. I'm sure most of you are familiar with the ASPRE trial, which has demonstrated that by giving aspirin at 150 milligrams nightly from 11 to 14 weeks till 36 weeks of gestation to high-risk women identified by the Fetal Medicine Foundation combined screening, the rate of early and preterm preeclampsia can be substantially reduced by 80% and 60% respectively. With regard to number needed to treat, to prevent 1 case of preterm preeclampsia, we have to treat 38 high-risk cases. This number increases to 69 when our focus is on early preeclampsia with delivery before 34 weeks of gestation. As for preventing small babies, the numbers needed to treat range from 16 to 30. For perinatal death, the number needed to treat is 34, and these numbers are very respectable. Though I'm happy that through our first trimester screen and prevent strategy, we can achieve good results for preventing preterm preeclampsia, there is still a proportion of high-risk women who's not benefiting from aspirin prophylaxis, as shown in these red bars. An important point that I want to make is to understand why some aspirin-treated high-risk women develop preterm preeclampsia. Firstly, we have found a significant interaction between aspirin usage and history of chronic hypertension in the prediction of preterm preeclampsia, which indicates that there is no treatment effect in high-risk women who have chronic hypertension compared to those who do not. Adjusting for aspirin usage and the interaction between aspirin and chronic hypertension, independent predictors for the development of preterm preeclampsia are low PLGF mom, less than 0.712 mom, and very high estimated risks. Women with risks of 1 in 2 to 1 in 10 have a 6-fold high risk of developing preterm preeclampsia, and women with risks of 1 in 11 to 1 in 50 have a 2-fold high risk of preterm preeclampsia compared to those with risk of 1 in 51 to 1 in 100. Our results have shed some light on who we need to follow up more closely during pregnancy, despite aspirin prophylaxis, and that they are offered more frequent monitoring of blood pressure. This could be in the form of 2 to 4 weekly clinic assessment of blood pressure, depending on the observed blood pressure measurements, together with home blood pressure monitoring. What is unclear to us is whether aspirin truly stops early onset preeclampsia from happening, or whether aspirin reduces the severity of the disorder, leading to a delay in onset and therefore delivery. This exploratory analysis supports the hypothesis that aspirin prevents preeclampsia by delaying the gestational age at delivery. By delaying the onset of preeclampsia, more cases of term preeclampsia are created from those who are meant to develop preterm preeclampsia, resulting in a significant reduction in the rate of preterm preeclampsia, but the rate of term preeclampsia is unchanged. The diagram on the left shows the distribution of gestational age at delivery with preeclampsia in the placebo and aspirin groups in the aspirin trial. This demonstrates that in the aspirin group, the incidence of early deliveries with preeclampsia is substantially reduced. In addition, aspirin appears to have the effect in delaying the gestational age at delivery with preeclampsia. According to the diagram on the right, the aspirin-related delay is greater for earlier than later preeclampsia. Many of you have asked if the Fetal Medicine Foundation algorithm works elsewhere. I can confidently tell you yes. Here are the results on screening performance in a total screened population of more than 10,000 Asian women. Fixing the false positive rate at 10%, the detection rate was 62%. At a fixed false positive rate of 20%, the detection rate was 75%. Now let's take a look at the data from the FMF as well. So for East Asian women, when we fixed the false positive rate at 10%, the detection rate was 50%, while fixing the false positive rate at 20%, the detection rate was 75%. This graph in the middle schematically compares the results between the Fetal Medicine Foundation and my cohort, and the results are comparable. We were also interested to find out how the NICE and ACOG approaches to screening would perform in Asia. Very clearly, you can see that the FMF triple test is superior to ACOG and NICE recommendations in predicting preterm preeclampsia. So where are we now with our research? The next question that we have is whether we can further improve the screening performance. So before I finish, I think I would like to touch on some recent development with the use of maternal ophthalmic artery Doppler in the prediction of preeclampsia. This is the work of Fetal Medicine Foundation evaluating the potential value of maternal ophthalmic artery Doppler at 11 to 13 weeks of gestation, alone and in combination with the established first trimester biomarkers of preeclampsia, including uterine artery PI, mean arterial pressure, and serum placenta growth factor and PAPA, in the prediction of subsequent development of preeclampsia. And this was a prospective observational study in women attending for routine hospital visit. This visit included recording of maternal demographic characteristics and medical history, ultrasound examination of fetal anatomy and growth, assessment of flow velocity waveforms from the maternal ophthalmic arteries, and calculation of the second to first peak systolic velocity ratio, and measurement of mean arterial pressure and serum biomarkers. Modeling demonstrated that the addition of peak systolic velocity ratio improved the detection rate at 10% false positive rate of preterm preeclampsia provided by maternal risk factors alone from 46.3% to 58.4%. Maternal factors, mean arterial pressure, and uterine artery PI from 65.9% to 70.6%, and maternal factors, mean arterial pressure, uterine artery PI, and placenta growth factor from 74.6% to 76.7%. The PSV ratio did not improve the prediction of term preeclampsia provided by any combination of biomarkers. So I think we need to watch this space in relation to seeing whether this ultrasound marker would take off in terms of being included in the combined testing for preeclampsia screening. To conclude, in relation to future direction, although we have a very good combined test for the prediction of preterm preeclampsia, but there's still a lot of room for improvement. I think there are 5 areas that we need to focus on. First is multi-omics systems biology studies. Placental senescence, I've touched on placental aging in our work, mitochondrial dysfunction, and when it comes to placental biomarkers, I think placental RNAs and placental proteins are still the mainstay of our interest. Another area of interest would be endothelial cardiovascular biomarkers, endothelial RNAs, and endothelial proteins. And lastly, ultrasound markers. Certainly, we'll be very interested to see more research groups in evaluating the use of ophthalmic artery Dopplers. And I know that there is also ongoing work with the use of placental 3D imaging as well as elastography. Thank you very much for your attention. And here comes the end of my talk. I hope you have enjoyed it.